Health influences attractiveness more than almost any cosmetic tweak because nearly every attractiveness cue is secretly a health cue.
Well, so give people the concrete examples, right? Because this is where it gets actionable for you.
Weight loss often creates a bigger appearance change than an expensive procedure. It literally reveals your jaws and cheekbones. Sleep deprivation shows up on your face within days. In fact, there are controlled studies where people were rated as less attractive, less healthy, and less worth socializing with after just 2 nights of bad sleep. And smoking, heavy alcohol, age the face dramatically. Smoking alone cuts your collagen production by nearly 20%.
And fitness. People think the gym's for the body. It is. But getting fit lowers body fat in the face as well. Improves your skin, your sleep, your posture, your confidence. It's a stack of attractiveness upgrades in one habit.
And here's the punchline of the segment. Most people dramatically overestimate the niche hacks and dramatically underestimate the basics, the things that we're talking about.
Yeah, and we see this, right? A guy comes in, sits in my chair, asks about a procedure, and I'm looking at him thinking, honestly, you need 8 hours of sleep and to stop drinking on weeknights. That would do more for your face than anything I can sell you today.
Which is a wild thing for a surgeon to admit on camera, right? That, hey, what I'm doing with my hands isn't going to help you as much as something you can do yourself. It's not good for sales.
It's the most honest thing in the episode, though, right? The best version of your face is usually the healthiest version of your face. We have a whole episode just on eating, clean eating. And actually, a lot of our episodes basically wind up being a healthier person, right? The PFAS episode, the forever chemicals, right? Glyphosate, eating a healthy diet, a Mediterranean diet. All these things with the GLP-1 episode, all of these things make a healthy person, and a healthy person is attractive.
We got to be careful, Ben. We might put ourselves out of business.
I'm pretty happy with the job that we do, but I'd also be happy to see people get to a new plane of existence. I'm okay with that. Hopefully,
Totally
I'll
agree.
retire by then, though.
Yeah.
Okay, this is the part everyone's waiting for. So we're going to do a tier list. The 2 facial plastic surgeons ranking the Looksmaxing menu. Okay. We're gonna take it from the S tier down to the F tier. Lee, are you ready to make some enemies online?
Let's ruin some supplement company's day.
Right. S tier, that's the highest impact, best evidence, available to basically everyone. And Lee, start us.
Sleep, top of the board, free, and it touches your skin, your eyes, your body composition, your mood. If you do nothing else, fix your sleep.
So you and I both have sinus and snoring institutes. You're in Florida, I'm in Texas, and we're busy. We focus about 50-60% of our time simply on sleep. So that really rings true to us. Body composition and weight management. Biggest visible facial change for most guys carrying extra weight. Sun protection. Daily sunscreen is the single best anti-aging intervention in all of medicine. There's a gold standard trial on this, right? Daily sunscreen users showed about 24% less skin aging over 4.5 years, and also not smoking.
Yeah. Treating acne is the next one. Clearing the skin changes how an entire face reads, and it's genuinely treatable. Why can't you just give me something and make it go away? Well, it's not that easy. It really isn't that easy. I mean, you many times I'll have someone come into the office and based on their symptoms, which are going over into the chronic sinusitis realm, I'm getting facial pressure, I'm getting dental pain, I'm getting headaches. And their scan, it's really not showing a whole lot of chronic sinusitis, but their symptoms are sure consistent with it. And I see structural issues there that may be at the root of it. And I treat them as if they have chronic sinusitis. And they're wondering why I'm putting them on antibiotics, even though I don't think they necessarily have an active infection. Explain that to me.
Yeah, I mean, look, a lot of times the infection doesn't show up in the CT scan. CT scans were never even a part of the main diagnosis core from the American Academy for decades. It only came in just shortly after, in the early 2000s, about 2004 or 2003, as an adjunct. A CT scan always undercalls what you see, which is why quite often I'll go in and take a look if I see telltale signs like bony thickening and narrowing, but I only see a very, very tiny amount of change on the CT scan. I'm going in with a scope, a fiber optic scope, not just looking from the front of those. I'm going in and looking around at the actual openings and trying to see some telltale signs there as well. Quite often you find actual evidence of chronic sinusitis on the scope where the CT showed very little. So the consensus from our academy is that it's a clinical diagnosis with a scope and or CT in general. It's not hard and fast. The CT scan is not the end all be all. It helps us quite a bit, but by the time you've already got a tiny little bit of thickening on the CT scan, when you look inside of there, you can see gross evidence of drainage and chronic sinusitis. So very important to make that distinction.
Yeah, I think that's just a very, very important point. I'll say the way that I discuss it a lot of times with patients when we're dealing with really these three different concepts: the concept of allergy, the concept of chronic sinusitis or chronic inflammation in the lining of the sinuses, and the concept of structural issues that are maybe at play that are making both of them or one of them worse. I point to the door of the exam room. And I say, if that door is open 6 inches and I need to get through it, one of two things has to happen. Either I need to lose weight or I need to open the door. Okay? And this is usually, I'm saying this after there's been a course of medical therapy. Okay? Whether it be antibiotics, steroids, and we'll talk about this, nasal sprays, whatever it might be. And they may or not have gotten complete improvement from that. The medications, what I just treated you with, that was trying to lose weight, okay? It didn't work. Didn't lose enough weight to get through that door. Now I got to open the door, right? I've got to change the structural things that are an impediment to great airflow. And airflow in the nose and in the sinuses, and I'm going to let you talk about gas exchange and that type of thing, why it's so important. But that's a big deal, okay? So I open the door. If I open the door, now I can walk through no problem. Everything's great. Life is wonderful. But what if I start gaining weight again? If I start gaining weight again, I might start having trouble getting through the door. So that's where I've still got to treat the underlying allergy, even though I've made the structural change.
Yeah, a lot of people miss that because they're coming in with their mindset already kind of glommed onto one idea because they were told they had allergy or sinusitis, and they get confused between the two. The two interplay. There's a lot of interplay between stuffiness, drainage, face pressure, ear pressure, and the two entities that mostly cause it, allergies and chronic sinusitis. Remember, at any given time, if you're getting swollen inside your nose, you have the opportunity to have a combination of those things. We're trying to treat things that we can treat to take swelling down and structurally change the openings so we don't wind up revisiting that in 6 months.
How do allergies really affect kids differently than adults? What should parents look for? How do we treat it differently? How do we test it differently? Are we using immunotherapy in children? Is that safe? What do you think?
Those are a bunch of really great questions. That's a loaded issue. Children are not just little adults. I mean, they do behave differently. Anybody who's ever given their child Benadryl knows, and then watch them bounce off the walls instead of fall asleep like you do, knows that they're wired differently. And so you have to understand it at a very different level if you're going to be treating them as a physician. So you want to make sure, because you're developing, one of the most, I think, difficult things to understand, to ascertain, and to navigate is how they are doing in school. I mean, a big marker for us as parents is developmental milestones. You can obviously see kids, with allergic shiners and a little crease above their nose because they're always wiping it. And we can sort of say, yeah, they might be allergic. But when you completely swell your nose shut, it starts a domino effect that can result in decreased school performance and decreased milestone or decreased, what do you call it? How do you say that? Decreased milestone meeting marking. I don't know. So basically, you want to make sure that the child is breathing properly, sleeping properly, and therefore doing well in school. Sometimes a child won't tell you what's wrong with them. It's their mood and behavior change. They start to they get grumpy. They start to act out and have behavioral issues at school. You might see grades go down, but you also might hear from the teacher, they're really hard to control right now. They're having a lot of outbursts or they're falling asleep.
Yeah, and when the main issue for a child is nasal obstruction, not breathing through their nose, you see this when you see things like kids with enlarged adenoids, right? Enlarged adenoids, enlarged tonsils, generally in kids, that's actually an allergic phenomenon. But even just classic nasal obstruction from pure allergy, swelling in the lining of the nose, when a child is not breathing through their nose, there are changes in the facial skeleton. So the facial skeleton is actually changing, it's forming in childhood. You get an elongated face, an elongated jaw or mandible. And what can that lead to down the line? It can actually lead to adult obstructive sleep apnea, right? Which we've talked about sleep apnea ad nauseum in prior episodes. And
well, your midface doesn't develop either. And so you're right, you have this adenoid facies, these allergic facies, yeah.
Yeah, so it really is a big deal, right? If you're going to catch this, you really do want to catch it early because childhood allergy can cause the development of these other types of things. Childhood allergy untreated also increases the risk significantly of adult asthma as well. So when should a parent look into this for their child? If their child is having chronic symptoms that are unresponsive to standard over-the-counter medical therapies that their pediatrician is recommending for them, then they should probably seek a specialist to look into the allergies more closely, and especially an otolaryngologist like ourselves to make sure there aren't issues such as chronic sinusitis, enlarged adenoids, enlarged tonsils that could also be contributing to the issue.
In children, it's a little different. I mean, a lot of the obstruction that we notice in children with sleep-disordered breathing, snoring in children, mouth breathing in children, comes from the adenoid and tonsillar tissue that's hypertrophied, that's bigger. When we say hypertrophy, we mean that it's enlarged. So the enlarged tissue at the back of the throat, the tonsils, and removing it can have an immediate effect. And so one of the first things that we do if somebody comes in for snoring in a child with enlarged tonsils is we remove the tonsils and see how they do.
Yeah, and so that was actually shown in the CHAT trial, the child adenotonsillectomy trial, which showed that removal of tonsils and adenoids in pediatric patients with obstructive sleep apnea showed a really, really significant improvement in AHI, or the number of obstructions they had per night. So in kids, to your point, that's a really big deal. Taking those tonsils out in a child with obstructive sleep apnea is a very important indication.
So if children are not breathing well at night, we know that they do poorly in school. There's a noticeable detriment for getting lower grades and more days missed. And when you remove the tonsils and fix that sleep disordered breathing at night, that goes away. So I think we should talk a little bit about what to expect when you have the tonsillectomy versus a child versus an adult, because there's a lot of misinformation about it. How do you talk to patients? Do you tell them, do you sugarcoat it? Do you tell them it's going to hurt? What do What's your spiel when you talk to a patient about a tonsillectomy, child versus an adult?
So pediatric tonsillectomy, and in full disclosure, I really don't do pediatrics anymore in terms of tonsillectomies. But when I did do peds, the kids, they really bounce back so easily. And so, yeah, first week it's going to be very significant pain. Child's not going to eat very well. Hydration is the most important thing for that first week. If you have a very low weight child, that becomes a bit of an issue, right? Certainly you want to keep the hydration up, but you have a low weight child, you certainly don't want to drop the weight too much more below that. There's the risk in kids when you're dealing with bleeding after tonsillectomy, which is the big major complication that you can get. If a child has a very significant bleed, that can be life-threatening. When an adult has a very significant bleed, not quite as much, right? So parents have to understand that type of complication and the rate that it can happen. And you could do everything absolutely 100% right, and afterwards a child could cough, and there you go. All of a sudden, there's a significant bleed. So parents need to know that. They need to know that that's a complication. They need to know that their child is going to not feel great for that certainly that first week. Second week will be much better. But kids tend to bounce back much quicker than adults. When I speak to my adults with tonsillectomy, I tell them, it is really going to be a terrible first week. I'm not going to lie to you, okay? You need to know that. Now, usually I'm doing tonsillectomies in adults for obstructive sleep apnea, and they're like, look, I don't care. I just don't want to use that CPAP machine. So, they're okay with it, and they can make that choice themselves.
The thing where tracking your sleep makes your sleep worse, Lee, it has a real name.
It does. It's called orthosomnia. Sleep doctors actually coined it in a paper back in 2017. And the name's perfect. Ortho means correct or straight. Somnia means sleep. They modeled it on orthorexia. When the obsession with eating perfectly healthy food becomes its own disorder.
So orthosomnia is then?
Well, it's the perfectionist quest for perfect sleep, driven by your tracker, that actually causes anxiety and insomnia. Real patients started showing up at sleep clinics not because they had a sleep problem, but because their app told them they did. This happens to me all the time in the office.
Yeah, me too.
Yeah, they'd see light, restless sleep on a graph, get anxious, start trying to force perfect sleep, lie in bed worrying about their score, and that anxiety is exactly what keeps you awake. Look, there is enough to cause us anxiety these days. We don't need a device on our finger causing more.
Right, so we're trying to help everybody, but we invented a sleep disorder by trying to optimize our sleep.
Yeah, that's the dark comedy of it. The pursuit of the perfect number became the problem. And here's the cruel mechanical irony we talked about earlier. The more anxious you are, the more you lie in bed awake but still. And the device often scores that stillness as sleep. So you can be lying there miserable, anxious, and the tracker says, great night. The instrument and your experience completely divergent.
Well, so, how do you spot orthosomnia in yourself? What are the tells? How do you know when you're in the middle of that kind of weird state?
So if you're checking your score before you even check how you feel, bad, okay? A bad number ruins a morning you'd otherwise have felt fine in. You feel anxious if you forget to wear the device, or you can't sleep without it. You're spending more energy managing the data than improving your behavior. If that's you, and be honest about it, the single healthiest intervention might be to take the thing off, at least for a couple of weeks.
And it's probably not lost on you. Notice the irony for a sleep tracker company, right? The best outcome is sometimes that you stop using the product. Uh-oh.
Which is exactly why you, the human, have to stay in charge of the device, not the other way around.
Right. So let's flip to the genuinely important side then, right? Because trackers can also catch real problems. When should your sleep data actually send you to a doctor? So you're wearing a watch or a ring, you're getting up, you're looking at trends, you're trying not to look at it too often. What should alarm you and send you to someone like us?
So this is the part we don't want to undersell. We really want to emphasize this because it's where the devices can genuinely actually save someone. A tracker is a smoke detector, or think of it as a smoke detector. A smoke detector going off doesn't tell you what's burning, but you'd be a fool to ignore it, right? Here's where the alarm matters.
So run the list. Let's do it.
Okay. Persistent daytime fatigue. You're sleeping 7 or 8 hours by the tracker, but you're exhausted every day. Loud snoring, frequent awakenings, your blood oxygen trend dipping overnight, a wildly irregular schedule, and a big gap between how much you think you slept and how the device or you actually feel.
So the top headline for us as surgeons who treat the airway would be sleep apnea, right?
Of course, this is the big one because untreated sleep apnea isn't a cosmetic issue. It's tied to high blood pressure, heart disease, stroke. The technology here has genuinely leapt forward. As of 2024, both the Apple Watch and the Samsung Galaxy Watch have actually FDA-cleared features that screen for the breathing disturbances of sleep apnea, mostly by watching for those overnight oxygen dips.
But, and this is crucial, but
screening is not diagnosing, obviously. Even Apple's own data, their watch correctly flags people who have apnea only about 2/3 of the time. So it misses some, which means two things. If your watch flags you, take it seriously. Go get a real sleep study. But if it doesn't flag you and you've got every symptom, loud snoring, gasping, exhausted all day, don't let a green check mark talk you out of getting checked. Don't let the check keep you from the check. Myth number 1, a stronger jawline will change your life.
Reality, attractiveness is multifactorial. We know that there are certain norms, but you know that there's so many things, including emotion and personality, that goes into it. One feature, even a great one, doesn't move the needle the way these communities promise. Nobody's entire life is being held hostage by their jaw. And if you think it is, BDS might be a diagnosis you have. We've literally given people better jawlines, and it did not by itself fix their life. I can promise you that.
Yeah. Myth number 2, testosterone is the answer. This one I want to spend a second on here, because it's where real harm can happen.
Go.
Most young men chasing testosterone have completely normal testosterone levels. The symptoms they're describing, low energy, soft body composition, low drive, low confidence, they overlap almost perfectly with sleep deprivation. And then we see that all the time. And people come into our office, say, oh, I think I have low T, or they've been started on testosterone, even with normal levels, and they come and they say, wow, you know what, I'm still feeling like crap.
Here's the sequence that normally happens, Lee. You start snoring. Nobody says anything about it because we think Uncle Jack snores and it's funny. Or it's annoying, so he goes in the other room. You actually slip into sleep apnea, your weight's going up, and your growth hormone that comes out between midnight and 4 a.m. drops, so your testosterone goes down to low normal. It's not great, but it's not abnormal yet. Your thyroid also usually goes off a little bit down to low normal, and you feel bad. But the root cause, so you wind up at a low T center, and they tell you, yeah, your T is not where it should be, let's jack it up. But unfortunately, that usually makes the sleep apnea worse, and the cycle continues.
Yeah, so who came first, the chicken or the egg?
Right.
And in this case, it's the sleep deprivation, the excess body fat, the chronic stress, the depression that caused the really mild decrease in testosterone level, not the other way around. So they're often treating a sleep and lifestyle problem with a hormone.
Yeah, and messing with your hormones, it's not free. In a young, healthy man, taking testosterone you don't need can shut down your own production and tank your fertility, and recovery isn't guaranteed or quick. This is a real medical decision with real downsides, not a supplement aisle confidence boost.
And I don't really think that the fertility impact is spoken about enough, because you can literally sterilize a male by giving them testosterone.
Yeah, you can wipe it out.
Depending on how far you take it and how long you do it for, it could be unrecoverable.
Yeah.
Right? So fix the sleep, the body fat, the stress first. For the vast majority of guys, that's the testosterone fix.
So myth 3, you can completely redesign your face naturally as an adult.
Here's the reality. Adult facial bone structure is largely established. You can absolutely improve what you have. Leaner, better skin, better grooming, better posture. You can't restructure the skeleton with exercise and a jaw gym.
Myth 4. women only care about looks.
Well, that one's actually correct. No, I'm teasing. The reality, and this is straight from the research and frankly from being alive, confidence, communication, humor, status, kindness, personality, and health all carry enormous weight. The communities that insist it's all bone structure and describing a world that doesn't actually exist.
Myth 5, if I'm not attractive enough, I need surgery.
Reality. Surgery is not the answer to every insecurity, as much as we as surgeons would like to think so. And coming from two surgeons, it's definitely not the answer when the real problem is how someone sees themselves rather than how they actually look. We turn people away for this. A scalpel can't fix a perception problem. So, Dr. Ben, is rhinoplasty only done for cosmetic purposes, or are there other reasons to do rhinoplasty?
No, I mean, what it's come to be known as, rhinoplasty, is certain approaches or a level of complexity to the surgery that you're doing on the nose. Make no mistake, you can do an open septoplasty. You can lift the skin up to come down on the top of that septum. So it's not just the approach. And there are, as you pointed out before, there are closed approaches. There are open approaches. And then there's the whole new concept since 2018 of preservation rhinoplasty. That could be a whole show on its own. So, rhinoplasty has become associated with the cosmetic procedure to make your nose look different. But there's actually a whole other side to it. It's a level of reconstruction that's designed specifically to help your breathing, and they call that functional rhinoplasty. So the designation is cosmetic rhinoplasty versus functional rhinoplasty. That's things like nasal valve reconstruction, which was an early episode of ours. And that's trying to combat somehow the instability of the nose. There are some non-surgical approaches or minimally invasive approaches, but the surgical approach is part of a functional rhinoplasty. Also, putting in different things that you might want to do, supports to the columella, this crazy little lobule that people pierce every now and then, hanging down here. The sidewalls, like we talked about, straightening out the top of the septum, both cosmetically and getting it out of the airway in an open septoplasty. All those things are part of a cosmetic rhinoplasty. So not all rhinoplasties are created equal. The difference here, which is the next thing we're going to talk about, is it covered by insurance? Yeah, functional rhinoplasty can be covered by insurance, but that doesn't mean that cosmetic rhinoplasties are. It's where you're changing the cartilages that the insurance companies care about, right? They don't want to pay for your self-esteem issues. They don't want to pay for your cosmetic preferences, how you want to fix your nose, how you want it to look. They don't think that should be a burden on the public dollar. So Lee, do you talk to people about functional rhinoplasty? Because I know you do a lot of laser work inside the nose that doesn't require a surgery.
Yeah, so here's what I tend to get, and I'm interested to hear what you say about this and how you address this. So I'll get, for example, an older patient whose tip has rotated down over time. They've developed progressive nasal obstruction. When I do this, all of a sudden, they can breathe beautifully. And or patient that has had previous trauma to the nose where the nasal bones have been crushed in on the septum. So it's actually the crush in of the nasal bone that's causing the nasal obstruction. So now you have a patient that needs a type of rhinoplasty to get that tip back up where it needs to be in order to open the nasal valves and get them breathing again. You need to break the bone in order to get the bone out where it needs to be. You present that to the insurance company. The insurance company says, heck no, that is a rhinoplasty. We're not paying for it. What do you do?
Well, quite often, actually, it doesn't fall under cosmetic rhinoplasty because what you're doing is a closed reduction of a nasal bone, which is covered by insurance typically. And then, there are a lot of ways to deal with tip ptosis. Most of the time, this tripod, a la Jack Anderson, the tripod here has fallen off the end of the septum and is now hanging down. And you can take not just the skin, but the entire SMAS envelope, the thicker tissue underneath the skin. You can do an ellipse of skin up here and a scar revision and just raise the entire nose up. It takes you 10 minutes to do.
Yeah, but doctor, I don't want a scar on my face.
Well, it has to be closed properly, right? I mean, and so if this is from age, I guarantee you that if you get it up in here where there are horizontal lines, you won't see it at all. I don't have any problem with it being seen, even in close-up photographs. To answer your question, though, that's one way to have it covered by insurance in a very simple way, easy to recover from. And then you don't have to open the nose up and do a lot of complex things that maybe blur the lines between cosmetic and functional. S tier, that's the highest impact, best evidence available to basically everyone. Lee, start us.
Sleep, top of the board, free, and it touches your skin, your eyes, your body composition, your mood. If you do nothing else, fix your sleep.
So you and I both have sinus and snoring institutes. You're in Florida, I'm in Texas, and we're busy. We focus about 50-60% of our time simply on sleep. So that really rings true to us. Body composition and weight management. Biggest visible facial change for most guys carrying extra weight. Sun protection. Daily sunscreen is the single best anti-aging intervention in all of medicine. There's a gold standard trial on this, right? Daily sunscreen users showed about 24% less skin aging over 4.5 years, and also not smoking.
Yeah. Treating acne is the next one. Clearing the skin changes how an entire face reads, and it's genuinely treatable. All S tier. None of it viral. All of it works.
Okay, so the A tier, right? Strong evidence, high impact, slightly more effort or cost. Go.
A real skincare routine, and by that I mean the boring evidence-based core. Sunscreen, a retinoid, gentle cleansing, not a 12-step shelf of serums. Strength training and cardio.
Strength training and cardio. Longevity also. We're getting into health span and lifespan.
Yeah.
Also,
it's all related.
Yeah, absolutely it is. It all ties in. And a good haircut and grooming, right?
This is all you. This is all you, Ben. You got the best hair I know.
Right. Find a barber who actually knows your face. I'm terrible. I'll find a person and I will just stick with them. I've been with my girl 10 years. It's the highest return on time and the whole board.
Now, I have to admit here, I got a haircut yesterday by someone new. So everyone's going to have to tell me, what do you think?
Yeah, we didn't want to bring you down this early in the morning.
Oh man.
No, it looks great.
That's cold. It
looks great.
I've got very thin hair, so it's kind of hard.
Right. And also dental alignment, braces or aligners if your teeth need it. Facial hair optimization, right? The right beard generally reshapes the perceived jawline. No surgery required.
Yeah, and it's kind of interesting because we see it a lot as surgeons. Many times the people that come in with really big full beards are people that have really weak jaws, or what we call retrognathia.
Yeah. Yeah, because it actually fills out this space, and a lot of times your jaw sits back, but you put a little beard in there and it looks strong.
Exactly. So the next two are in our world, Ben. Treating nasal obstruction and sleep apnea. People don't connect these to looks, but chronic mouth breathing and bad sleep wreck your face and your energy. Fixing breathing is health, and it's aesthetics. And we know, for example, when we see children that can't breathe through their nose, they get that, what we call adenoid facies, that malar flattening there in the elongated jaw, and then they are also at risk for sleep apnea as adults.
So hair loss treatment when appropriate, and this one's important because it's evidence-based, but also it's readily available now, and it doesn't require surgery necessarily. There are really good evidence towards topicals and surgery. Finasteride minoxidil, they have real data behind them. In one large evaluation, more than 90% of men were stable or improved. That's medicine, not a hack. Talk to a doctor. There are real considerations, but it works.
Yeah, and potentially real side effects, because sometimes people are taking these medications orally as opposed to just topically.
True.
And there can be some real side effects from them.
True.
Right. So the
But
next
there's also been great advances in the surgery. You know, the single unit transfer, where somebody really pays attention to how the hair grows, can look absolutely natural. That gets a little expensive, but like we talked about in a previous show, you know, you can go to different countries, and it's not that it doesn't have that many side effects and complications. So it's one of the things that you can actually travel for and cut costs if you need to.
Yeah, absolutely.